Welcome again. We're going to be talking about, I'm going to be trying to give us a community update on the Conference of Retroviruses and Opportunistic Infections, Croi 2023. It was the 30th anniversary of this conference. And Anne, you said you've been to all except this one? I think that's
yes, all except this. This is the first one that I hadn't gone to.
Wow. So this was quite a momentous occasion for lots of the speakers that they had invited, especially for the opening sessions. They had Tony Fauci speak and a community member who gave a fiery, impassioned speech, which I'll hopefully get to share with you as we go through. But it was quite the meeting to attend here. It was here in Seattle. This is a copy of what the program guide looked like. And right next to it, I was going to show you a video that I took from the conference center, but for some reason, I can't get it to play. So that's sort of why this is an offset image. But the new conference center, if you haven't gotten a chance to be inside it yet, I think it was really a beautiful place. I think they did a great job in terms of having it feel open, and there was lots of glass, so you could see lots of visions of Seattle from outside. And one of the community advocates who was there, Jim Pickett, was saying even though he knew he was just looking at apartment complexes and things like that, he thought it was still really a beautiful view, and he was really impressed with that. So I wanted to just jump into some of the science that I think is going to be affecting us. And the first is lots of news about the long-acting injectable that they call Cabenuva, which is a combination of long-acting cabotegravir and long-acting rilpivirine. And the study that I'm going to start off with is talking about how this strategy of using injectable long-acting therapy may actually be feasible for people who are struggling to stay engaged with the way we traditionally offer HIV care and who can't really seem to maintain viral suppression on oral therapy, on the antiretroviral therapy that they take by mouth. Let's see if I can go here. Yep, there we go. And so just to remind you all, this is a new strategy. It's a new therapy, and it's 2 intramuscular injections in the butt that are usually administered by a healthcare provider. And at first, we saw that they were approved for monthly administration, but now that has also, we've had research show that we could do this every other month or every 2 months. Just to review that, but this has only been approved for people who have currently suppressed viral loads and they're on a stable regimen. We don't know if it's going to work for those who don't have viral suppression, and that's what this study was about, looking at this strategy as starting it with someone who may not actually have an undetectable viral load. So there was a previous study that was done, and it was done with 50 of the people who get their care at a place in San Francisco called Ward 86. Go ahead, Mark, you had a question.
Yeah, my question is, did they come out with, is there any long-term side effects to the long-acting injectables? I mean, because we know the daily medications have problems. Is there anything with the long-acting injectables to be concerned about?
None that I saw in terms of the data that was at the conference this year. I don't know if Rachel, did you see anything that, or have you heard of anything that might be?
Yeah,
it's
concern? A good question, Mark. So I think that these drugs were really, the data that supported their FDA authorization came from some bigger studies, registrational studies that looked at this drug combination exclusively in people who are suppressed. Cabenuva is very similar, or sorry, cabotegravir is very similar to dolutegravir, so the side effect profile is very similar. And rilpivirine is the same drug as the oral drug. So I think the side effect profile is exactly kind of as would be expected for these 2 types of drugs. So still has metabolic complications. There are some concerns with Cabenuva about, sleep or psychiatric concerns similar to dolutegravir, but pretty rare. Overall, I think thousands of people, if not, probably, 100,000 people have received rilpivirine in the oral form, fewer in the acting form. This is different from, because these are depot drugs, people are getting like a really big dose of them that slowly releases over time. So it's different from the TLC ART formulation, where people are getting almost like a microdose of it because it's formulated differently. So that's really sort of the same kind of, I'd say, long-term complications are exactly what you'd expect from these drugs taken orally. And then really short-term adverse events are really just the injection site reactions that most people tolerate fairly well, but some people do get a lump or redness or tenderness at the injection site that lasts a couple of days.
Okay, thank you.
And so this study was looked at, and this is a previous study that was looking at people who get their care at Ward 86, and they call this a safety net HIV clinic. Here in Seattle, we have something that we call the MAX clinic. It's a low barrier clinic, but this is basically a clinic that's going to serve mostly people who have a low income. They often have other issues also besides HIV, including substance use disorder, mental health problems, unstable housing. And everyone who switched to injections with an undetectable viral load maintained that viral load. And 80% of those who had a detectable HIV viral load at the baseline achieved viral suppression. And some of those people did it for the very first time. So this was exciting with those 50 patients. And that was a previous study, as I said. So there's now a current study. And so they started this program in San Francisco called SPLASH, which stands for the Special Program on Long-Acting Antiretrovirals to Stop HIV. And what this involved was extensive support for individuals, and they each had case managers. They had phone or text reminders about their injection visits and reminding them. They had follow-ups for those who missed their injection appointments. They even had some street-based nursing services that they offered. So there was a lot of support around people who went through this special program. So this study was with these people, and it had 133 people at the same ward, Ward 86, and it went from June 2021 to November 2022. And this time in the study, they had no need to have viral suppression at the baseline. They didn't have a need as well to do an oral lead-in, which we may have heard, where you would take oral cabotegravir and rilpivirine before you would go into the injectable. They didn't need to do that. They just went right into the injectable. So they had monthly injections, and then if they maintained their viral suppression on those monthly injections for 6 months, they could move to a every other month schedule. So in this study, it was 88% men, 8% cis women, and 4% trans women. The racial and ethnic breakup, you can see most of them were Latinx, and then you had 32% white, 16% Black. 33% of the people in the study were stably housed, 58% were unstably housed, and 8% were actually homeless. And almost, there was a lot of substance use disorder in this group. A third of them were currently experiencing stimulant disorder use, and 38% had some sort of major mental illness. 76 were undetectable at the start of the study, and 57 had detectable viral loads. And most of these people never, ever had achieved an undetectable viral load before. And so the median CD4 count for that group was 200 compared to the undetectable group, which was 600. So 74% of the total population got their injections on time. So they made their appointments and could get it. All 76 of the undetectable people maintained their status during this study. So, which is something that we would probably expect if they were already coming into the study undetectable. 55 of the 57 detectable viral loads, the people with detectable viral loads, they achieved their undetectable status, and that 4 should be removed. I'm sorry, I didn't get that. So they had really a good success rate getting people who were detectable to undetectable. 2 people, unfortunately, had a resistance mutation. And this was known by the study team, but it was thought that if they were put into the study, maybe this would still have a chance, but they were kind of already expecting that this might not work for them because of the resistant mutations that they had. And this is the reference for the study. So this was a great finding, especially people are really excited about these long-acting therapies. And so it led to a lot of discussion at the session, and I'm going to try to capture a little bit of what was brought up. And Alistair, I saw you had your hand. Did you want to ask your question?
You may be about to answer it. For the two that had the resistance, that suggests that they needed to be transitioned onto something different?
Yes.
Was there any particular way that they handled that? Were there an alternate regimen that they could be put on, even though they already had significant doses, blood levels in their system for the following, presumably 4 to 8 weeks?
Right. And that I do not know the answer to. I just know that it was thought that this would be a long shot. The way it was sort of described, it was like they didn't know if this would work, but these people were desperate for some sort of treatment, so it was worth a shot. And I can't really answer your question.
I can talk a little bit about that.
Sure, go ahead.
So actually, there's a really exciting part of this discussion is that I'm actually part of a small group in the ACTG who's going to spearhead a follow-on study to this to sort of figure out what we need to do to move the needle to make this something that everybody can do across the country, that doesn't need to be a study, that it's accepted to be able to use long-acting drugs for people who have a hard time taking oral medications and aren't virally suppressed. So we spent quite a bit of time talking about this. In these two cases, Monica Gandhi said, were people who had protease inhibitors available to them, but have just never been able to take oral antiretrovirals. And so they were offered oral protease inhibitor based regimens after this. Those were available to them before and after this study. And she said that they felt, both she and the patients felt like nobody really lost anything because there were people for whom that regimen was never working for them beforehand in terms of the feasibility of it, but it's still available for them as an option. The other sort of follow-on option to that is the new drug called lenacapavir, which is approved, and it's actually approved for people with difficult to treat HIV. And so it's actually approved for people that have viremia, but not necessarily in combination with cabotegravir. And so they've been able to get compassionate use cabotegravir from ViiV to be able to combine with lenacapavir for those people who have an NNRTI mutation. They pretty much had NNRTI mutations. So mutations against the rilpivirine, and so they've been able to secure that. And I can't talk too much about the sort of plans for this next study yet because nothing has been really decided. So I don't have a lot that I can report back on, but I will keep everybody posted. But I think the idea is to sort of think about all of these things, like what about resistance and development of resistance, and how do we make this something that people can just get in their clinics wherever they are, and what sort of level of evidence do we need to be able to get that, bridge it from research into practice.
Right.
Thank you.
So this is one of the questions, these sorts of questions came up. And Mark, you have your hand up. Go ahead.
Yeah, on that topic of resistance, with these increasing combinations in single pill form, if they're resistant to one component of the combination, isn't it rather stupid to continue to take it? I mean, it's of obviously no value. So how are the drug companies, that are obviously making a lot more money out of packaging them all together in these new formulations, how are they going to then separate this out so people aren't on unnecessary medications?
It's a good question. I mean, I think from a provider standpoint, the vast majority of the people I take care of are on a oh, I'm hearing weird echoes. Are on a single drug
could everyone make sure they're mute? Sorry.
Yeah, so the vast majority of people that I take care of are on a single tablet regimen. The people who are the main exception to that are folks who've been living with HIV for a long time. And for the most part, we try to provide only the medications that are necessary. And so sometimes we do take the drugs apart, meaning provide the medications in their individual drug forms rather than in a combined way when it's not appropriate to have them combined.
Well, it's kind of like, TAF had, Discovery has 2 medications in. So
Right.
if you're not resistant to TAF, but you're resistant to what is it, entrancidine or whatever, I'm probably
Yeah.
mispronouncing. So is the drug company making just TAF available without the other medication?
It's a
Or
good
is that something
question.
it's not?
It's a good question. I don't want to talk about it too long because I think Michael had a lot of good things to
Okay.
talk about. There's a good reason for people to stay on emtricitabine, and that's that it forces the virus to actually be a less fit version of itself. So even if there's resistance, there's advantages in terms of forcing the virus to be less good at what it does for that particular combination. But yes, your long story short is that we take apart the single drug regimens for people for whom it's not appropriate.
Thank you for that. And so I just wanted to give you a sense again of like this study in people who are not virally suppressed. The results were shared. And so some of the issues that came up for people was, number one, these people in the study had intensive support services around them. And is this applicable? In other words, is this study applicable to other places that might not have access to such intensive support? And someone even brought up about the UK, and the UK only allows every other month dosing of injectable cabotegravir and rilpivirine, not the monthly regimen. And so they were bringing it up as an idea that it might be riskier for them to start if because it'd be riskier for people who might be late or miss a dose because they'd be going for 4 months instead of just 2 if they were to miss that dose. And so someone brought up one of the things that you just heard Rachel say about evidence. What sort of evidence would it take to convince regulators and for the guidelines to see this as a feasible approach to using long-acting therapy, because a randomized controlled trial might not be possible for a population that can't take oral therapy to begin with. So it might show some difficulties there. And one commenter also brought up that in the early AIDS epidemic, that clinicians did a lot of things without a lot of data and saved a lot of lives during that time. And so this might be a time where we go forth and do this for people who are not getting virally suppressed. And Monica Gandhi, the woman who presented the study, says that we need innovations for this population specifically if we want to end the HIV epidemic. And if we use these creatively and boldly, long-acting antiretroviral treatment could really make a dent in the epidemic, reaching those less numbers of people that we might not be able to reach. And so I wanted to leave these thoughts with you and to hear your input about this. What do you think about this as a strategy for people who aren't virally suppressed?
I certainly think it makes sense. I think we have to recognize that sometimes people can't do what the ideal situation is. And so what can we do? And given how little resistance there was and how much efficacy there was in reducing, the viral load, you may not always need that level of intensive support. Right. And it can still give you a better result than either doing nothing or doing what was already not working.
Alistair, you had your hand up.
I raised my hand for the same sort of response that basically, while resistance exists, I can remember back in the late 1990s, early 2000s, where Steve Miles at UCLA Care Clinic, basically it was explained that while people who have resistance to everything at that point was available as a medication, they actually could first of all, he had a model that basically said that HIV treatment is stepping stones across a river.
Mm,
And in the early stages, you can still see the bank behind you,
mm,
and you can only see a couple of stepping stones in front of you. But there's more and more research going on, and we just need to go from stepping stone to stepping stone to finally get all the way across the river. We ain't there yet, but we're on our way. But his basic take was that when people develop resistance to one of the available sets of meds, then if they switched to another one that lasted for them for a while, if they absolutely had to, they could switch back to one of the earliest ones, and that would make the virus itself sufficiently unfit that it was protective, but it wasn't going to last all that as long as we would like. And that somebody in that situation basically would have to every 6 months or every 4 months, as their viral load came up again, switch to another of the ones that they'd taken and just keep jumping to keep the virus in their system unfit to threaten them, but not unfit to replicate. And that made quite a lot of sense, because if you've nothing else available, rather than just give up, go back a couple of stepping stones and then move forward again until more stepping stones appear in front of you that you can then move on to. And lots of us are now, halfway across the river, still can't see the far bank, but we've managed to be undetectable because of switching regimens without necessarily becoming resistant to the prior regimens, but just to potentially better combinations with less side effects. So if we develop resistance to the ones we're on just now, we could theoretically fall back on some of the ones from the late 1990s, early 2000s, to tide us over a bit longer until the next ones are coming out, like lenacapavir or whatever is coming in the future.
Which I'm going to get to those presentations towards the end about that specific drug. I like your image there also of those stepping stones across the river. I think it's a poetic metaphor for antiretroviral therapy and the choices that people have to make in getting there. Let me
thank you.
Go through. Yeah. So also related, this is a different study, but they just basically, we have concerns about body weight. And so this was looking at people who were on Biktarvy, which is bictegravir, tenofovir, alafetamide, or TAF, and emtricitabine. And it's specific to people who started on that drug and then switched to cabotegravir and rilpivirine. And it was shown through this study that it rarely affects the body weight. So that was a good outcome for people. So switching from the combo containing TAF or TAF, which has been strongly associated with a weight gain when it's used with an integrase inhibitor. Few people experienced any substantial reduction in weight. Not all integrase inhibitors have the same impact on weight. So people gain more weight when they're taking dolutegravir or bictegravir than when taking elvitegravir. And weight gain is greater in people receiving an INSTI as a first-line treatment. So the study that brought up this issue about weight gain is called the SOLAR study, and it randomized 687 people with HIV in a 2-to-1 ratio to switch to injectable Cabenuva or to stay on Biktarvy. So that's what they were being randomized to. And of the 454 people who were randomized to the injectable treatment, 175 people actually chose to do an oral lead-in first, but they didn't have to do it. So there were some people who did that. There was 17% of the people in the study were cis women, 29% of them were Black, and 69% of them were white. Interestingly, in both of the arms, the cabotegravir arm, the Cabenuva arm, and Biktarvy arm, 38 and 34% of the people were overweight, and 21% and 24% were considered to be obese. After 12 months, after a year, the body weight of people showed little change between these groups. And the same for the body mass index, the total body fat, and the total muscle mass. So it seemed like similar proportions of people in this study experienced weight gain or weight loss. So there was really no difference between Cabenuva and Biktarvy. In fact, the actual study was a non-inferior study. So Cabenuva was considered to be non-inferior in virologic efficacy to Biktarvy, and switching was efficacious, well tolerated, and it improved people's treatment satisfaction. And that's probably the biggest thing, as you can imagine, with long-acting injectable therapies, is that people tend to have a lot more satisfaction around it. And so these are some of the things that people said in the study. I don't have to worry about remembering to take my medication every day, or it's just more convenient to get the injections every 2 months. Someone said that they don't have to worry about carrying their HIV medications with them wherever they go, and they don't even have the pills to remind them about their HIV status every day, which was a great relief. And they don't have to worry about others seeing those pills or finding those pills. And so you can imagine these sorts of things really added to that tremendous sense of satisfaction when they went to an injectable form of the therapy. So I wanted to switch to another study now, and this study I think is really exciting. It relates to studies that were done here in Seattle and in San Francisco. And so this study looked at a vaccine, and it was found that a vaccine could halve the rates of gonorrhea. And this was in a study in France. And it's the first vaccine that has shown some efficacy against a bacterial sexually transmitted infection. This study also demonstrated the effectiveness of doxy-PEP. And doxy-PEP, if you're not familiar with it, is taking a doxycycline 72 hours after a sexual experience that was with condomless sex. So in other words, if you had some chance of having an exposure to a bacterial STI, you would take this doxycycline as a form of PEP. So it's just like PEP for HIV, where you're getting the medicines after the encounter. And that's why they call it PEP and not PrEP, although I do believe they're looking at doxy-PrEP as well. So this study was referred to as the DoxyVax study, and it was stopped actually in August of 2022, mostly because of the doxy-PEP study that was done both here in Seattle and San Francisco. That study found that they cut the risks of chlamydia and syphilis really big. And for HIV negative men, it was 87% decline in the risk. And you see 75% for HIV positive gay and bi men. And gonorrhea was cut by about 55%. And now it was interesting that this study that was done in San Francisco and Seattle here showed that it worked for anal and urethral, but not throat gonorrhea. So because of this, the people who were running the DoxyVax study requested some sort of early confidential analysis of the data that they were collecting in their study, and it was determined that it would be unethical for them not to offer all of their participants doxycycline as PEP, and so that's why PEP was added to their vaccine study. So people are being offered both the antibiotic doxycycline and the vaccine until the end of 2023. So they've kind of opened up their study to this because they determined that it would be unethical not to offer this because of the results that we did at our clinic as well as in San Francisco. So there were 546 participants that made it into the study, and they were randomized to either get the vaccine only, doxycycline only, both of them, or neither of them. And everyone in this study was also taking PrEP for HIV. And the vaccine is actually not a vaccine for gonorrhea. It was a vaccine for meningitis B, and it's, I'm not sure exactly how this brand name is said, Bexsero, I assume is how it's said. But basically, you could use this meningitis vaccine because meningitis and gonorrhea are from the same genus, Neisseria. So in this study, there was a very high baseline among the people of bacterial STIs, and I describe that as meaning in the last year they had either syphilis, gonorrhea, or chlamydia. 68% of them in the past year had gonorrhea, 50% had chlamydia, 20% syphilis. And the average number of sex partners in the study, they had about 10 partners in the last 3 months. All of these participants were cisgender gay and bisexual men. Their average age was around 39. They were 80% white. 85% of them were born in France. 332 were taking doxypep. 170 did not. And 257 got the vaccine and 245 did not. So people who were getting doxypep said that they used it and it came about to 83% of the time. And the time that it took them to use between sex and actually taking the pill was about 27 hours. And there's a very low report of side effects, and most of them involved gastrointestinal problems like nausea, some stomach pain, but that was a very low number. So it was shown that doxypep in this study prevented syphilis and chlamydia 84%. So the efficacy rates that they calculated for syphilis, it was 79%, 89% for chlamydia, and 51% for gonorrhea. Now that's with doxypep that was added to the study. Doxyvac, the vaccine, showed a 51% efficacy against gonorrhea. And that number, if you can remember from what I showed you before, in the doxypep study, it was similar. It was 55%. So one of the biggest concerns about using an antimicrobial antibiotics is developing resistance to that. Using too much antimicrobials can lead to bugs that are resistant to the antibiotics. And so they did see high levels of resistance in gonorrhea, but they saw no resistance develop in chlamydia. And according to the study team, it's impossible to test syphilis this way to see if it's resistant to a drug or not. These were considered to be small numbers of samples that were tested. And so they were seeing some levels of resistance, but it still needs to be further studied. They were seeing larger effects outside of just these 3 bacterial infections. So for instance, with MRSA, at the beginning of the study, the men who were on doxypep, about the swabs that they did, about 1.8% of the swabs came positive for MRSA. And for the men who didn't get doxypep, 1.2%. So that's at the beginning of the study. But afterwards, you can see doxypep guys, they had a 10% increase there almost. You can see MRSA. So they had some concerns that this levels of resistance might not just be affecting gonorrhea, but it could be affecting other larger bacterial infections. And so they were concerned for that. And so that's one of the concerns that is about this strategy. And the guy who, let me see, there we go. They talked about next steps at the study. And so there's the guy who was talking about this. And he actually said he doesn't see guidelines immediately endorsing the vaccination just after this, or even, looking at just this one study and the efficacy that they observed. And so he also said that this vaccine is expensive. It's about $200 for a single dose, and that we don't know what the duration of protection is, whether or when you might need a booster, and they need to do modeling to establish the effectiveness and the cost effectiveness of gonorrhea vaccination. Also, this was a vaccine that was meant for meningitis, and if studies are consistently proving efficacious, then there might be an incentive to develop one specific to gonorrhea. And so there's still more research needing to be done. But I found that these studies were exciting because we can see some sort of biological intervention to a problem that we know is everywhere in the world. STI rates have been rising for lots of different populations in the US and around the world. And so it's good to see that we have some sort of intervention that we could perhaps see this stop or be lessened. So the same study, the US DoxyPEP study, also looked at the gonorrhea resistance, and they only saw in this study modest increases in the proportion of gonorrhea infections with significant resistance. And there was little difference in the resistance rates between people taking DoxyPEP and not taking it. So they saw some, but not something that was too significant. So DoxyPEP after sex appears to be ineffective, however, for cisgender women. And this is another big concern besides antimicrobial resistance. So this same strategy of taking doxycycline after sex didn't protect cisgender women in Kenya. And that's where the study was focused. They've tried to come up with some possible explanations for this. It's a very stark contrast, and they posited maybe there's anatomical differences, maybe there was variations in antibiotic resistance in the areas where the studies were conducted, maybe there was suboptimal adherence. But this is something that we need to look at, because bacterial STIs in women can lead to lots of complications, and there's a intervention that needs to happen. So this study was called the DPEP Kenya trial, and it happened in Kisumu, Kenya. And that's an area that was considered to have high STI rates and a high prevalence, especially of resistant gonorrhea. There were 449 non-pregnant cisgender women who were roughly between 18 and 30 years old, taking already HIV PrEP to join this study, and they were randomly assigned to either taking doxycycline after sex or to do the standard of care, which in their area was a quarterly STI testing and treatment after a diagnosis. About 60% of these women were on hormonal contraception, and 37% reported transactional sex. In this study, at baseline, 18% of the women had a bacterial STI, about 14% chlamydia, about 4% gonorrhea, and less than 1% syphilis. They completed all their follow-up visits. They even had weekly surveys, and there was a great response, 80% to that. 80 women became pregnant during the study, and they suspended DoxyPEP during pregnancy for those women. And still, the STI rates were high during the study. They had an annual incidence of 27%, and they were comparing this rate to rates of men who have sex with men in high income countries. But it was concluded that that should have been doxy, sorry, forgot the Y there, did not significantly reduce the risk of STIs for cisgender women in this study. And so this was a very bleak finding. And it was surprising because the study doesn't, suggest that this would be a case based on biological differences, and antibiotic treatment for STIs does not differ for men and women. So they didn't expect that using antibiotics for prevention would be biologically different. And yet they saw this different. And so they're needing to suss this out. So the results of this study is deeply disturbing, and the study team was saying they are committed to understanding why it didn't work for this population and determining the next steps for how to identify prevention tools that will work against STIs for women and by women. So switching to cure, this is just a sort of a report of something that many of us already knew. This is a report finally about a man who we know as the Dusseldorf patient, a German man. He received a stem cell transplant using HIV-resistant donor cells over a decade ago. And then about 4 years ago, he stopped taking ART, and he's had no detectable HIV, and he's finally been declared cured. And this happened right at the start of the conference. It was in Nature magazine. In fact, there's the title of it there. And it was good to see there's finally a scientific report in a reputable journal about this case, because this was the one case that was not being reported or recorded or considered in the cases that we have around cure through a bone marrow stem cell transplant. In fact, just to remind us, we have there Timothy and Adam were the first, and then we have Mark. Oh, whoa, what's going on there? So Mark is the new Dusseldorf patient. He came out during an interview with the Amsterdam. It was in Amsterdam, the media in Amsterdam. And don't forget, we have the New York patient who was a woman who had a special type of transplant that was done with with cord blood. And then we have the City of Hope patient who I was lucky to meet back in October, and who's going to be coming out with his status and his story soon. However, since the computer wants to seem to go on, the really interesting thing is that there were many unanswered questions related to the bone marrow stem cell transplants with donor cells that are resistant to HIV. And there was a poster, and this poster was basically the first known case of a viral rebound in a person who received a stem cell transplant from a donor with the double CCR5 delta 32 mutation. So in other words, someone who had those cells that were resistant to HIV infection, who got their transplant with them, had a viral rebound, which is the unfortunate story here. So he's a 67-year-old individual, no detectable HIV 15 months after his transplant. He was put on a treatment interruption, and then his HIV came back 8 weeks later. Okay. So why did this happen is the big question, and they don't have any answers, but some of the suggestions is maybe it was the strength of the conditioning chemotherapy before the transplant. Maybe it was the intensity of the graft versus host reaction. All of those we know can play a role in eliminating HIV, but the 5 people who've been cured so far this way had different conditioning regimens. And so we don't really think it might be that, or can't really explain why it might be. Also, some of the people had mild, or some people had no graft versus host disease. And so we can't really say what it is. So there's a lot of unanswered questions about this. Now, of course, stem cell transplants are far too risky for us to consider them being a cure. And so we only are doing these in people who have a need to treat life-threatening cancers. These situations are medically intensive, they're costly, and they're not really going to be scalable. So this is not a cure that is for the world. In fact, this is a quote from the Dusseldorf patient himself. He says, in case it was necessary for him to do this because of the leukemia, but he says it's a really rocky road. It's a very rocky road. And so these are not easy therapies to go through. So they do, however, offer clues to us and clues to researchers that might be able to be developed into a more widely applicable approach that'll help us to achieve either viral clearance or long-term remission without ART. So those are the, let's not go forward. So I just wanted to stop there. Those are the 2 cure-related things I wanted to bring up, and I haven't been able to see what's going on in the chat. Do we have any questions, or did anyone want to bring up anything?
This is Alistair. When we were talking about the 5 patients that have been cured,
yes,
or known to be cured, when they got their allogeneic stem cell transplant, did that completely replace their own immune system?
Well, no, I would say just obviously in the case of, are you talking about the case of the rebound?
Well, it's sort of relating to why the rebound might be happening. This is where I am not sufficiently knowledgeable, but my understanding is that the idea is that with the Berlin patient, his immune system was wiped out. He got a transplant, and it actually took him two transplants to engraft properly. But his own immune system was completely replaced by the transplanted immune system.
Right.
Was that true for the other 4?
Not in the same ways that I understand that you might be saying. So let me put it this
Not
way.
necessarily in the same way, but was the end result that there was no component of the original immune system left? It had all been replaced by the transplanted cells.
I do not know the answer to that question, especially when it comes to the New York and the City of Hope patients.
Right. The reason I'm asking is that if the entire immune system was replaced, then theoretically, a really significant amount of the reservoir would have been wiped out.
Right.
And in the situation of the rebound, if that rebound patient, if that patient's immune system hadn't been completely wiped out and replaced, then the portion that was left might be sufficient to cause the problem.
Right. And so, I talked to Steve Deeks, who many of you on this call may know, about this case of the rebounds. And Steve believes that, there may have been HIV still in Timothy's body somewhere, that it was just not able to reproduce. In other words, that he may have still had some sort of latent reservoir that just wasn't able to get out because it had no cells to infect. And so we might have seen with this rebound case here, someone who didn't have a full chimerism, a full transfer into the new immune system. And so, even after being off of treatment for 15 months, it may not have been long enough. There may have been cells that were infectable, and that's what caused it. They're going to be puzzling this through a little bit more, but it was the first case that they have documented of someone who survived the transplant and yet was seeming to have, who's now had a rebound. There was a case of someone who passed from their cancer, but they seem to have had a CXCR4 version of the virus and was having a viral rebound when they passed. And so this is the first time with one of the CCR5, R5 tropic type viruses having a rebound. So sort of distressing, and I'm sure they're going to be puzzling through why that was. But I just thought it was interesting simultaneously, not only that we had the Dusseldorf patient finally be added to the other 4 in the lineage of cure, but then also to have this news that came through the NIH, and it was through a poster about this viral rebound with a situation that many of us may already assume. I think, it's easy that we get thinking about like, oh, if someone's getting a stem cell transplant, and if they're having those donor cells that are mutated, so they are not able to allow HIV in, that would be enough. But it may even this case of rebound might show us that even when we have gene therapy that might be doing that through modification, making people's cells HIV resistant, that might not be enough still to control or cure HIV. We still might have the chances for some sort of viral rebound. And so we need to probably, when we say like that, it's going to take a combination of approaches to cure HIV. It may be even for gene therapy, definitely needs some sort of immune modulator that will keep the immune system looking for HIV rebounds to happen and sort of coming across them when they may happen and being able to stop them. So I just thought that was an interesting cure study, and it was not one that was talked about from the stage, so to speak. It was in a poster. And so I just wanted to bring that to your attentions. And I had a copy of the poster. I just haven't had a chance to get it off of my phone and onto the computer here. So I was going to share that with you, but I will be able to email it if any of you want to see the poster for yourselves afterwards. Any other questions before we move on? I'm sorry I didn't get to see the chat. So we were talking before. I see that Tasia and Rachel were talking about the case of doxypep in women.
I've been trying to help answer questions in the chat so that you can just keep presenting. But
okay, cool. Thank you for that.
Can I ask a question about the doxypep?
Sure.
I know that a long time ago, there was a study where the women didn't do what they said they were that they didn't do what they were supposed to do. In this particular study, how did they figure out what the women did and whether they said they did what they did?
That's a great question, and that's exactly what I was trying to, like, in short form type to Tasia. So yeah, so the kind of long and short of it is that the partners prep study did very well among partnered women, and then the
Fem prep and voice.
Fem prep and voice did not do well at all. And essentially, when they used a bunch of measures of did people take their medication, so they asked women how many
And the
doses
voice,
did you take? And yeah, and the voice with the gel. So people said, yeah, I'm taking it, because
but then they really hadn't.
they hadn't, exactly. So like people in the study, the study investigators are scary to them, probably. They're like authority figures. So they asked, did you take your, and people wanted to stay on study, they're getting reimbursed and things. So there's all sorts of reasons to tell somebody that you're taking your medication, right?
Right. No, I'm not trying to be pejorative. I'm
Oh,
just
no,
trying
no,
to
no, I
say
know. I'm
that that's,
just,
I believe that that's what happened. And I
Yeah.
just wondered if how they tried to figure it out for this
Yeah.
particular study.
No. So it's just kind of explaining the backstory. Sorry, and for other folks who may not know that as well, is you. And I think what they found out is that when they actually did dried blood spots and tested for levels of tenofovir, what they found is that any of the prep versions work quite well among people who take them. It's just that most of the people who said they were taking it weren't taking it for probably a lot of societal pressure reasons and stigma and all sorts of things. And I think the TLDR on this study, which was actually presented by Janelle Stewart, who was recently used to be at University of Washington and recently moved to Minnesota, just for local interest. They don't have like doxycycline blood levels, and they certainly don't have levels of doxycycline in the tissues, meaning like vaginal mucosa levels. And so I think that's sort of like the next step, is to try to get more data to understand if the issue is that the doxycycline doesn't go in the mouth. And if it doesn't go in the mouth, why? Is it stigma? Is it concern? Is it, what's causing people to maybe not take it? And then if it does go into the mouth after sex, is it not getting to the places that it needs to go? Is it not getting in as high of concentrations? And we know also from PrEP studies that tenofovir gets higher levels in rectal mucosa than it does in vaginal mucosa too. So I think we know that like women or people with vaginas are probably at a disadvantage compared to people who are having anal sex, in terms of just being able to kind of bathe the area that might be exposed with the medication that needs to be there. But yeah,
Thank
so
you.
they're trying to work out all of those possibilities. Like, is it the drug doesn't go in the mouth, or that the drug goes in the mouth and doesn't get where it needs to go?
Got it. Thank you.
Yes, and I found that very interesting too, that there's still going to be more to suss out from that. So I wanted to talk a little bit about monkeypox, and especially in monkeypox in terms of how it relates to people with HIV, and specifically with people who have uncontrolled, or I might even want to put in there undiagnosed HIV. And as you see this part of the presentation, you'll understand why I wanted to say undiagnosed. So in this study, the results of this, some people who are experts think that we need to make monkeypox, or mpox, as they say now, an AIDS-defining opportunistic infection. And that's because of the global numbers. And so they were talking, in this case, they were looking globally, and there are about 400 cases of mpox among people with HIV whose CD4 counts were below 350. And that led to some really nasty things, which I started to write in the slide, like all of the possibilities, and I just stopped because it was really sort of bumming me out. But they were talking about necrotizing lesions that led to tissue death. People's lungs were affected negatively. There was sepsis involved, all from having a low CD4 count. The overall mortality rate was 7%, and it was 27% in people who had a CD4 count below 100. Let's see. So the silver lining, a part of this study, was that, well, if people have well-controlled HIV and if people received an Mpox vaccination, no one died. So in other words, if your HIV is controlled, no one died. If they had a vaccine, no one died. And no one died also if they had a CD4 count that was above 200. So those were all sort of silver linings of this sort of, but they were also warning about the IRIS condition, the immune reconstitution inflammatory syndrome. And the reason they wanted people to be aware of this is that you could have a worsening of symptoms when people start ART with a very low CD4 count and Mpox. And so a lot of people in this, they noticed that it was around roughly 21 days after they started showing Mpox syndrome symptoms that they would start their ART. And this is really of concern mostly because if someone hasn't had an HIV test, they may already have a low CD4 count without knowing it. And if they get Mpox, it could have catastrophic outcomes. And I just know anecdotally to share with you in my life that there are many people who seem to never get an HIV test until they get very, very sick. And then they find out that way. And since we have Mpox around now, even though it seems like our numbers are dwindling here, it still exists, and there's still a problem in many other countries. And so having never tested for HIV is probably one of the quickest ways I've known that people get to that low CD4 count without knowing it. And then they get really sick, and only after they crawl into a hospital, figure out that they have HIV. And so getting Mpox on top of that could become very catastrophic for people. And that's why they want to make this an AIDS defining syndrome. So I just thought that was interesting, and I wanted to share that with you. Also, just I'm not going to go into this, but they showed that all of the generations of the smallpox vaccines protect against Mpox infection. So if you remember when over the summer there was a shortage of vaccine and there was all this concern about if the smallpox vaccines would protect against Mpox, these two different studies that were presented at Croi showed that it did protect against it. And I thought that was some good news in terms of Mpox. So going back to HIV treatment, integrase inhibitors.
Michael, can I ask a very quick question about Mpox?
Sure.
Do you know if they managed to collect any numbers about whether or not people who had received the smallpox vaccination last millennium, if that proved to appear to be protective?
That I do not know per se. I don't remember that being
that's the second study that you showed by BK Tatanji. That one is it. So that study was specifically in military personnel, and so most of those people had I think the average time in that study between getting a smallpox vaccine and getting and coming in to test for smallpox or for Mpox was 13 years. So I think a lot of the people had gotten one of the smallpox vaccines like a very long time ago, but I don't know if they know about like if someone had gotten it in 1975 or something. Right. I don't know that we have enough data on that yet, but there was like I said, in that study, I believe the average time between vaccination and the Mpox pandemic was 13 years.
Thank you.
And that is still something that they recommend. I mean, I just remember learning that over the summer myself, because there was that talk about having been vaccinated for smallpox back in the day may have been protective, but they didn't want you to rely on that, and they wanted you to get the newer vaccine to make sure of that. So moving on to this, the integrase inhibitors, these new inhibitors that we have that we were talking about with Biktarvy and dolutegravir, they don't seem to raise cardiovascular risk in people who are starting treatment. And so starting treatment showed that it did not lead to an increased risk of heart attack or stroke or surgery in the heart for people who have HIV who live in Switzerland, which is where this study happened. So just so you know, integrase inhibitors, the effects that they may have on cardiovascular risk have been uncertain. And although we know it's less likely to cause increases in cholesterol, people taking them tend to gain more weight. And so it created some questions about it. And so this study basically showed that it did not raise the cardiovascular risk. So I'm going to be going through a lot of these very quickly just because I was going through them. So there was also a study that was looking at combinations of antiretroviral therapy that involved tenofovir, alafetamide, and cobicistat. And they showed that combinations that contain these were linked to physical depression symptoms in women with HIV. So women in HIV who take TAF and cobicistat boosted protease inhibitors or integrase inhibitors were more likely to experience numerous physical symptoms of depression than women who were on other ART regimens. And so this suggests looking at drug combinations rather than individual antiretrovirals when considering whether HIV medication might be causing or contributing to physical symptoms of depression. So as you know, depression can manifest in several ways. There are non-physical symptoms such as sadness, hopelessness, despair, loss of libido, lack of pleasure, suicidal thoughts, but there also can be physical symptoms: sleep disturbances, tiredness, changes in appetite, weight gain or weight loss, aches, pains, and sexual dysfunction. And so 3 different combos were found to be associated with high physical symptom scores in the high depression score group. And that was TAF, emtricitabine, darunavir, and cobicistat, or as they call it, Simtusa. TAF, emtricitabine, elvitegravir, and cobicistat, or Genvoya, and TAF, emtricitabine, eltegravir, darunavir, and cobicistat. And I didn't get the brand name on that. I don't know if, Rachel, do you know the brand name for that one? I forgot to get it. Anyway.
Oh, I don't think
we don't have that one.
here. I don't think we have that one here.
Yeah.
We only have darunavir with TDF, I believe.
Okay. Yeah. So, but yeah, so that's why I couldn't find the other brand name, but that's because it's probably not in the US. There were 2 combos that had significantly lower symptom scores in the high depression score group, and that was TDF, emtricitabine, and efavirenz, or Atripla, and Complera, or TDF, emtricitabine, and rilpivirine. And then of course, the low depression score and no depression groups, the no drug combination was associated with a higher or lower rates of physical symptoms of depression. So those were interesting, I thought, especially for the well-being and the health of women with HIV. There was also a very interesting new method of PrEP that was going through its first safety studies. And this was a study that was looking at it specifically in terms of anal sex. And they were calling this new method an insert, which is like a suppository. But they were calling it an insert in this. And it was an insert that was going to be considered for PEP as well as PrEP. And it contained elvitegravir and tenofovir alafetamide, or TAF. And it was determined that this was safe to use and that it produced drug levels in rectal tissues that stayed very well above the protective levels for over a day. So this was the first human safety study of the rectal use of this insert. They had vaginal use data that was presented at the HIV R4P conference and showed similar results to this data here. And so these inserts are gently inserted into the vagina or into the rectum, and they dissolve within a few hours. And so if you were to look at one, and I couldn't find a picture of one, but they look like an oral tablet. They're really small. They're about 1.5 centimeters long and less than a centimeter wide. And they contain 60 milligrams of elvitegravir and 20 milligrams of TAF. And so this was a phase 1 study that was trying to assess the safety and the drug levels of a single insert in the 72 hours after rectal insertion. And then they did it again using 2 inserts. And so they had 23 HIV negative people, 17 men, 6 women in this study. And so that meant that 21 did a single dose version and then 19 came back for a double dose version. 8 of them were black, 13 were white, and 2 of them identified as other. And all of them seem to have quite a high body mass index. The drug levels that they measured were both in the blood, the rectal fluid, the cervicovaginal fluid, and in rectal tissue samples. Also, they looked at levels of tenofovir diphosphate, which is basically the substance that TAF turns into once it's in our cells. And they looked at this in rectal tissue cells. And the samples that they took were at 1 hour, 2 hours, 4 hours, and 6 hours after the dosing in the first study visit. And then at return visits, 24 hours, 48 hours, and 72 hours after dosing. So you can see how they were just doing this not only to get the safety information, but they were looking at the drug levels to see how it traveled through the course of time in the body. So they also did this interesting part of it. It was called an ex vivo model to estimate the efficacy, which is basically where they take the rectal tissue samples and they expose them in the lab to HIV, 100% infectious doses, and then they incubated that with either the drug or the saline as control. And then they measured the amount of the P24 antigen, which is the first viral protein to be produced when replication happens. And so the single dose of the insert, the P24 levels were 40 times lower than the control 2 hours, and then only 16 times lower by 72 hours. However, the double dose was 100 times lower than the control at 2 hours and still 50 times lower at 72 hours. And so this was cause, for them to, where are we going? Back. To basically say that this strategy should be studied further to see if it could become a new PrEP method. So just putting another tool in the toolbox of prevention with these suppositories or inserts.
Michael,
Go ahead.
Do we know why they use TAF instead of TDF, with TDF being so much less expensive than TAF?
I do not know the answer to that. It might be something about the drug company involved.
I would presume that it's because if you're trying to get the drug into the cells, into the tissue, that TAF actually does a better job. So
Great.
Yeah, so I think they've shown now that TAF versus TDF is better for PrEP, especially with respect to anal sex, because it does get really high tissue levels. I think there's a concern about whether or not it gets into the vagina at the same levels, which is part of why, there's kind of caution about using it with people that have vaginal sex. But I presume that it was because this was something that could be given and would get really high rectal levels.
It's nice to hear that there's a biological reason, not just a potential profit reason.
I think that there is. I have to say that, for some other studies, I didn't say this, in the chat, but like some of the HIV switch studies, it is because of companies looking at their drug versus competitors, for sure. But I don't think that's the case here. And would you agree that this is about tissue levels?
Yes. Let's see. Yes. Oh.
What?
Are you hearing me?
Yeah, we're hearing you.
Right. Yeah.
Oh, okay. Yeah,
yeah.
the answer is I think that's right.
Okay, great. So next study, I think I probably just chose this one because the headline around it was interesting. Cocaine was being tied to white matter lesions with people in HIV, and it was being considered a factor that leads to poor cognitive function. So cocaine use in people with HIV was associated with great white matter lesion burden, even after accounting for age and other risk factors like cardiovascular disease. So white matter lesion burden correlates also with poor cognitive function. And these intensities of white matter intensities, which are markers of the small vessel disease, reflect a decreased blood flow to deep areas of the brain and contributed to cognitive deficits. And they were saying that these have been observed at higher rates in people with HIV due to persistent immune activation and increased risk of medical comorbidities. And they say still, though, that aging and cardiovascular disease risk factors are the main predictors of the white matter hyperintensities.
Did they look to see if cocaine association was comparable in people without HIV, like cocaine just has this impact on people, or was the cocaine impact considered to be more so with HIV?
In the slides that I saw, they did not have a comparison with people who just used cocaine who did not have HIV. So I don't know if they're looking at the general population that way. So these are just some of the other ideas I want to bring up to you. So there was a study that was looking at anxiety and depression and saying that it was associated with different types of myocardial infarction in people with HIV. There was also a study that was called the Miracle HIV study, that was looking at preventing the worsening of subclinical heart disease. And we also had sex differences that were in the association of HIV with metabolic fatty liver disease. And they were concluding that indeed they have seen women having higher incidence of significant liver fibrosis compared to men, especially once they were at age 50 or after, and that there need to be future studies to target the adequate consideration of these sex differences in clinical investigations for this, to fill the gaps in knowledge for people with HIV. And then there's also a study of cabotegravir as PrEP in US Black men and transgender women. And this study was concluding that the protective efficacy of basically this long-acting injectable cabotegravir versus the oral version of tenofovir or Truvada, the protective efficacy remained high for US Black, MSM, and transgender women. And that basically their conclusion was that this is a powerful HIV prevention tool to increase access to PrEP and could be a way to address the continued racial disparities that we see in HIV acquisition and incidence in the US. And that was sort of where I was going to end things, because I thought that's what I found most from this conference, that there wasn't a lot of science that was groundbreaking or earth-shattering, but there was room then to talk about the continued disparities and trying to broaden, for instance, the people's access not only to research, but to all sorts of strategies of prevention and treatment. So there was concerns about race and concerns about sex and gender that were being brought up, at least amongst the community advocates that I got to meet. It seemed to be like their main concern of the 20-some scholars that they had come to Croi from 16 different countries around the world. And I just thought that working towards making things like this powerful HIV prevention tool accessible to the people who need it most is going to be a continuing discussion that we need to have, because right now I'm sure these are not within reach for people who need these tools, and we need to do something about that. So I believe that was my last slide. Oh no, I forgot lenacapavir. That's where I wanted to end it. So lenacapavir is where I wanted to add or end our study or end our discussion of the studies that were presented at Croi. So lenacapavir is a new ART that is working on multiple stages of the replication cycle. So if you just look here at the diagram, you can see that it can basically, as the virus is entering the cell, it can interrupt. And then you can see also it interrupts the capsid assembly and the virus assemblies and when it's releasing. So it works in multiple stages of the life cycle of the virus. And that's exciting. And so this study that I was just going to end with was showing that this new drug with 2 different BNAbs could be dosed at every 6 months for people with HIV. So it showed that the combination of these, you could take, get the treatment once every 6 months with these 2 BNAbs and lenacapavir. So they had 20 participants, 18 of them maintained suppression for 26 weeks after a single administration of this, and that it was safe and well tolerated. They had mild injection site reactions, and that this may mean that we have a potential treatment regimen that would be twice a year. And so it's now entering a phase 2 study. And so I thought, instead of ending on any sort of despairing note, that we would end the discussion with this, which is looking towards the future where we might have HIV treatments that every 6 months, twice a year. And I thought that was very hopeful. And so I just wanted to put the bug in your ear about our meeting next month. Will be on March, oops, where'd it go? There it goes, March 28th. 5:30 p.m. And I wanted to talk specifically to our local community members here, if they feel like it is time to move back to in-person meetings. And I just wanted to give an update that I was going to be talking to the meeting place where the Living Positively support group currently likes to meet, and see if we cannot get into the what was known as formerly Gay City, but now is the Sexual Health Clinic, or the LGBTQ plus health center, and going to see if they have spaces that we might be able to use there to have our combination meeting where we would have a hybrid approach where we would be able to meet in person, but then also still keep the Zoom option open. And I know some people have been wanting to do this, and so I figured it would be worth a chance to start that up. So that